Hello, this is Dr. Catlin. This is the lecture recording for Module 16K, Pulmonary Embolism, in your Pearson text. First, we're going to go over some terms. Your dead space, an area of the lung that's ventilated but not perfused. Embolus is a particle or aggregate of blood, fat, or pathogen, or a bubble of air. I know we tend to think of an embolus as always being a blood clot, but it's not necessarily. Lyse is to disintegrate. Pulmonary embolus, obstruction of blood flow in part of the pulmonary vascular system by an embolus traveling from one area of the body to another. Thromboemboli is emboli created by a blood clot. So what is a pulmonary embolism? Obstruction of blood flow in the pulmonary vascular system by an embolism. It can be a blood clot, it may be a tumor, it can be a fat or bone marrow from a fracture or other trauma, amniotic fluid released during childbirth, IV injection of air or foreign substance. I bolded fat because fat emboli are the most common non-thrombotic or non-blood clot type of cause of a pulmonary emboli. It's usually from a fracture of a long bone or adipose tissue or liver trauma. Incidence of a pulmonary embolism occurs in 1 out of every 1,000 people. It is a full or partial obstruction of one or more pulmonary arteries. So let's review the normal blood flow into the pulmonary artery. Normally the right ventricle, remember your heart, the unoxygenated blood comes into the right atrium, into the right ventricle, and goes over to the pulmonary artery. So the pulmonary artery supplies the blood into the pulmonary circulation. The pulmonary artery then branches off. All your little branches of pulmonary artery branches off into arteries, then into smaller arterioles, and then finally into capillaries. It forms a mesh that encases the alveolus. The partial pressure of oxygen is greater in the alveolus than it is in the capillary. So oxygen diffuses into the blood in exchange for the carbon dioxide that is moved. There needs to be a match between the blood flow through the pulmonary vascular system or the perfusion and the lung ventilation to have effective respiration. The body adjusts itself with constriction and dilation of the vessels to promote the match in exchange, in the gas exchange. So with the PE, there is a mismatch in the ventilation and perfusion. Normally the right ventricle empties completely into the pulmonary artery. The impact of a pulmonary embolus depends on the disruption that it causes. An occlusion of a large pulmonary artery leads to reduced gas exchange. It can lead to sudden death with the drastic drop in the cardiac output because the blood cannot move through the heart, as you see here. Lung tissue infarction occurs in about 31% of pulmonary embolus. It was interesting that the most common is in young, tall, thinner, and smokers. Smoking tobacco smoke is a huge factor, but young, tall, and thin is also a risk factor for a spontaneous pneumothorax. I just found that interesting, that for a lung infarction from pulmonary embolus, it's the same group that is higher risk. If this occurs, it leads to a formation of fibrotic or scar tissue. Sometimes that scar tissue is mistaken for an old pneumonia or a fungal infection or something, and they miss the fact that the person had actually thrown some pulmonary embolus that led to this lung tissue infarction. If only a small, it can also be obstruction of a small segment of the pulmonary circulation. In a patient with an acute PE or pulmonary embolus, the total dead space increases because the lung units continue to ventilate even though there is absent perfusion. A complete obstruction of pulmonary artery by an embolus causes an increase in the anatomic dead space or wasted ventilation. This increased dead space impairs the efficient elimination of carbon dioxide. And that's where it comes in. They used to do a VQ scan, ventilation perfusion scan, to diagnose pulmonary embolus. But that what they've discovered is that even though there's this increased dead space, the body compensates and perfuses to other areas so that you don't always see the ventilation perfusion issue with the pulmonary embolus. So that's why it's no longer the primary diagnostic test for a pulmonary embolus. So your risk factors, anything that can lead to a DVT, deep vein thrombosis, is a risk factor for pulmonary embolus. So stasis of venous blood flow, sitting for long periods of time, not moving the legs, very sedentary lifestyle, crossing the legs, something obstructing your blood flow to your legs, like really tight shoes or stockings, usually stockings. Vessel wall damage, altered blood coagulation, prolonged immobility, trauma, hip and femur fractures, which those are high risk for a fat embolus, surgery because of the sedentary pooling of blood, plus also emboli from fat, myocardial infarction, heart failure, obesity, family history, advanced age, oral contraceptives because of the estrogen therapy like postmenopausal, pregnancy, childbirth, tobacco smoke, and race, which is the African American has a higher potential for pulmonary embolus. The risk of a clot breaking off and forming a pulmonary embolus is most present in the first few days up to about 4 weeks, while the clot is still fresh. If it's coming from a deep vein thrombosis, the clot is still fresh, fragile, and not scarred. However, patients who carry out normal daily activities after a clot are no more likely to develop a pulmonary embolus than those who don't walk around. For years, if you had a clot where you were told to sit and not walk, which they found that does not mobilize it. Most pulmonary embolus occur from a DVT, but it can be de novo. De novo is, I believe it came from a Latin term, but it means without cause. Sometimes there's a PE and they don't know why. PEs are often from a malignant cancer or from trauma. So prevention, anything that prevents, you need to prevent the clots caused by deep vein thrombosis. So in prophylactic administration, anticoagulants, like in the hospital, if a person's is on bed rest before and after surgery, especially if they're having orthopedic surgery, compression stockings during surgery, and or pneumatic compressions. I've seen both on people. I looked it up trying to see if there's a difference between sequential compression with the air versus just compression stockings, the old socks. But the studies I could find doesn't seem to be any difference. But there aren't any studies out now to show if the ones on the feet, I don't know if you've seen them, the SCDs on the feet only versus up the leg. I cannot find if there's a significant difference in those in prevention. Early ambulation after surgery, elevating the legs during bed rest, frequent movement when they're when there's prolonged sitting or traveling, especially in a plane or long car rides. When you're traveling, taking breaks from sitting, flex your ankles while seated, drinking plenty of fluids, and wearing support stockings. I put this picture in here because I want you to think about when there's a pulmonary embolus that it's more than just a clot in the lung. If the pulmonary artery is obstructed, that blocks the blood flow from the right ventricle into the pulmonary artery. So your right ventricle will dilate. And your tidal volume when you're breathing is insufficient. The right ventricular wall has an increased tension, which causes some hormones to be released, which causes inflammation in the heart muscle. The right ventricle, because it's dilated and pushing with this increased tension, it has an increased O2 demand, which leads to atrioventricular shunting. The right ventricle gets ischemic and hypoxic with injury, so you have a decrease in the right ventricular contraction. Your right ventricular output is decreased, so there's less blood getting into the left ventricle, so you have a decrease in preload in the left ventricle, leading to less for it to be able to pump out, so you have a decreased cardiac output, which leads to a decrease in systemic blood pressure because there's a decrease in systemic perfusion of blood flow. And remember, our left ventricle not only pumps out systemically, it pumps to the coronary arteries too. So there's a decrease in coronary perfusion, and there's a decrease of perfusion to the right ventricle, leading to a decrease in oxygen delivery, and it can lead to obstructive shock and death. We will be talking about shock in a few weeks, but this was just a really good picture of thinking of a pulmonary embolus where it can lead if it's completely obstructed. Okay, so thinking of that will help you here when we get into common clinical manifestations of a pulmonary embolus. It depends on the size and the location of the embolus. Small emboli may be totally asymptomatic to minimal symptoms. When they do have manifestations, they're abrupt. Dyspnea, pleuritic chest pain is very common. Anxiety and apprehension is common. Sense of impending doom is usually a larger clot. They can have a cough, tachycardia. Hemoptysis is another major sign. Diaphoresis, tachypnea, crackles. You might develop a cardiac gallop. The syncope and cyanosis are more common when it's a massive MI. There's also the potential to have a low-grade fever with the pulmonary embolus. So you can see why it may be difficult to distinguish between a pulmonary embolus, a myocardial infarction, and pneumonia. You can look this up in your text on 1301, your clinical manifestations chart. Because if you're hypoxic, you're going to have restless chest pain, dyspnea, cyanosis, use of your accessory muscles, respiratory acidosis. That's if your respiratory exchange is decreased. Tachycardia, tachypnea, because it's more likely to be a shallow breathing, a feeling of impending doom. You want to give them oxygen, reposition them for decreased workload, is like putting them in a Fowler's position, anticoagulation therapy. I'll be covering more of that as we go along. Rupture of small arterioles due to arterial congestion. That's where you're going to start seeing the crackles, possibly cardiac gallop, and the cough, the dyspnea, crackles in the affected lobe. And you might see the hemoptysis. You will see hemoptysis because of the arterial pressure and rupture of those arterioles. Alveolar collapse related to tissue necrosis and inflammatory process will lead to hypoxia, dyspnea, productive cough, chest pain. Inflammatory process leads to that elevated temperature, that low-grade temperature, not a significant fever, your tachycardia, tachypnea. You can have a dehydration and even a cough. Okay, so fat embolism. I put two pictures on here. This is your chest petechiae. Often it's across the anterior chest and the arms, sometimes into the axillary. There's a sudden onset of cardiopulmonary and neurological symptoms, both, with these fat emboli, because you see these fat emboli go everywhere. Confusion, agitation, petechiae. You can see petechiae into the eyes here. What else? Delirium, decreased level of consciousness. Page 1300 goes into this some more. Collaboration and prevention. Early ambulation of medical surgical patients using pneumatic compression of legs, elevating legs, active passive leg exercises. These are things we already covered on prevention, but prevention, once the clot is there, especially if it mobilizes, but you want to prevent them. Remember, your compression stockings or pneumatic compression devices have to be the correct size to be effective. Too large or too small. Too large will not compress completely and be effective, and too small will obstruct blood flow. All your therapy is supportive. Again, you can look on your table on page 1301 on your clinical therapies. Oxygen therapy, analgesia for pain and anxiety, balloon catheter monitoring, that's with your wedge pressures, which we talk about in our congestive heart failure and cardiomyopathy, and measuring your pulmonary artery wedge pressure. You put in a Swan-Ganz, it gives you your right atrial, right ventricular pressures. It goes into the right pulmonary artery, so it gives you your pressures in your artery. When you wedge it, it gives you an indirect reading of your left-sided heart pressures. So you're assessing your cardiac output, monitoring your cardiac rhythm, because you're looking for arrhythmias or because of decreased perfusion. Okay, so there is pulmonary embolus criteria testing. There's three things your text talks about. There's three: screening prior to doing further testing, the PERC, the modified Wells criteria, and the Geneva criteria. Your text seemed to focus on the PERC, although when I was reviewing it, I like the modified Wells criteria better. Purpose of any of these is to decrease the risk with other testing when there's not a probable cause for a pulmonary embolus. And even if there's a low probability, a small percentage of, even if there's a low probability of thrombus, there's only a small percentage that will develop a pulmonary, even with a low probability, a small percentage will still develop a pulmonary embolus, so you have to, even if there's low probability, you're not going to do further testing, you're still going to be closely monitoring. So the PERC rule is applied to patients where the diagnosis, any of these is applied to a patient where the diagnosis of pulmonary embolus is being considered, but it seems that the person is at low risk. So with the PERC, they use a person's age, over 50 years old, pulse rate of at least 100, SAT of less than or equal to 95%, hemoptysis, estrogen use, history of surgery or trauma within the last 4 weeks, if they've had a PE or DVT in the past, do they currently have any signs of a deep vein thrombosis? If they answer yes to any of these, then you do further testing. Otherwise, only if all the criteria are no, you just monitor. The modified Wells criteria uses the same thing, but there is no age limit. They look at the O2 SAT, estrogen. They add pulmonary embolus being likely if they have a malignancy or treatment for cancer within the last 6 months. The Wells criteria actually does these questions combined with a D-dimer, looking for that thrombin lysis. So those combination, also the Wells criteria is if you're being treated for a pulmonary embolus, they use the Wells criteria and the D-dimer for prior to stopping or for a decision on stopping treatment. The Geneva criteria has the age greater than or equal to 65, malignancy that's active or cured within the last year, heart rate is 75 rather than 95, pain or edema in one limb. I didn't find much supporting the Geneva criteria, so I like the modified Wells, which for testing purposes, I'm probably going to go there. Diagnostic testing for pulmonary embolus. Plasma D-dimer levels. The D-dimer is a fragment of the fibrin that's formed during the lysis or the breakup of the blood clot, so it's specific for a thrombus. So it has high sensitivity of a thrombus, but low specificity for it actually being a pulmonary embolus. There is a great risk for a false positive with the D-dimer on a PE, and it becomes less specific with age, with the elderly population. Chest CT with contrast, I bolded because that is the main test that is completed to rule out a pulmonary embolus or for diagnostic purposes. It's even capable of detecting emboli in the periphery, in the peripheral vascular system. Lung scans use a radioisotope, so there is a risk for an allergic reaction to the dye. Cannot be used in pregnancy, and if they're breastfeeding, they have to abstain from breastfeeding for 48 hours. The CT pulmonary angiography, it's only used if all the other testing is inconclusive. It is really cool. I was going to put some pictures up here. You can actually see all the branches, and it shows the tiniest clots throughout the whole pulmonary vasculature. A chest x-ray may or may not show pulmonary embolus, but it's also using to help you rule out like pneumonia or something else going on in the lungs, like a pneumothorax. Your EKG, ruling out your myocardial infarction since symptoms are closely related. With the PE, they may have non-specific T-wave changes. Your blood gas, ABG or arterial blood gas, the tachypnea and hyperventilation will lead to hypoxemia and respiratory alkalosis. And tidal volume carbon dioxide. It shows how much CO2 is being blown off. If there's an impaired pulmonary perfusion, then your CO2 has dropped because you're not having that gas exchange and for blowing and getting rid of the CO2. Coagulation studies, they monitor the response to therapy. Your coagulation studies are your PTT and your INR. Remember, your PTT monitors your intrinsic clotting pathway and heparin therapy. The goal is to have the PTT at 1.5 to 2 times your control. Your INR monitors your extrinsic pathway and your oral coagulation, like your Coumadin. Your goal is for your INR to be 2.0 to 3. So anticoagulation therapy, we've talked about heparin in the past. They'll give an IV bolus followed by an infusion, and they start them on heparin. It takes 5 to 7 days to become therapeutic with your heparin, with your INRs, prior to being able to stop your heparin. Did I say that right? 5 to 7 days for your warfarin or Coumadin, for your INRs to be therapeutic so you can stop your heparin. I'm not sure I said that right. They may consider doing low molecular weight heparin, which is your enoxaparin, or Lovenox is the one we've talked about. Anticoagulation therapy is often started even if there's no PE, but they are high risk. But it's definitely started if there's a pulmonary embolus and or a DVT, deep vein thrombosis. Any anticoagulation therapy, there's a risk of bleeding, and watch for cardiac, hepatic, renal disease prior to using anticoagulation therapy, and there's an increased risk of bleeding if they're over the age of 60. I put in here introduction of XA inhibitors. Your text didn't really talk about them. In the last several years, more and more different, more anticoagulation therapies have become available. XA inhibitors, which we've spoken of in previous lectures, are being introduced more and more, and they are now actually being used to initiate for the initial treatment for pulmonary embolus. I couldn't find any really good studies to show comparison for those versus heparin. Some actually are doing the XA inhibitors along with heparin, so it was hard to tell if XA inhibitors alone how effective they are. I guess a lot will probably depend on the size of the pulmonary embolus and the amount of pulmonary emboli. So your XA inhibitors are rivaroxaban or Xarelto, but it has a higher risk for a GI bleed. The two preferences are Paxaban or Eliquis, but it has to be given twice a day. These medications are given for about 6 months, so compliance, once you get past more than one time a day, compliance can go down. Endoxaban or Savaysa, Savaysa, is a newer one. It is the first XA inhibitor that is daily use, so we may be hearing more about that one. Thrombolytic treatment or fibrinolysis. It's to break up or destroy the clot, the lysis. It's for massive pulmonary embolus in a person who's hemodynamically unstable. That is the only time it is used, because of the risk of bleeding is significant, especially intracranial bleed, and so it'll be used more for strokes and other things, but for pulmonary embolus only if hemodynamically unstable. What does that mean? With the blood pressure dropped, pulses, loss of consciousness, hemodynamically unstable, cardiac outputs in the gutter, the patient's crashing, they're going to die if we don't open this up and get rid of this clot. So it's persistent hypotension or shock, the systolic blood pressure less than 90, or a decrease of 40 points, 40 millimeters of mercury from their baseline blood pressure. That's a significant drop. So somebody like me that walks around with a systolic of 110, we're okay with the 90, maybe 80. But somebody that walks around with a systolic of 160, 40 points would get them 120 at 100. They're probably extremely symptomatic. So hemodynamically unstable. It acts by activating plasminogen to form plasmin and accelerates the lysis or breaking up of the thrombus. The class is tissue plasminogen activator. That's why you will hear them called TPA. The agents urokinase, streptokinase, and the newer of them is altipase, which is a recombinant tissue plasminogen activator, or recognizant TPA, which means it is made in a laboratory. Contraindications in pregnancy, recent surgery or trauma within the last 14 days, a recent GI or urinary bleed within the last 21 days. There's other things for thrombolytic treatment, contraindications, but I'm focusing specifically on the thrombolytic for a pulmonary embolus. Risks are intracranial bleed, systemic hemorrhage, and angioedema. Whole purpose of doing this is to decrease the death rate, dissolve that clot as fast as possible within a few hours. Nursing actions, you're doing neuroassessments, and this is, TPA is giving IV. It's a small bottle. It's given, I think, over like a 2-hour period. I don't know if Altepace is 1 hour, but it's a 1 or 2 hour period. During that time, initially you're doing every 15-minute neuro checks. I think it's like the first hour, and then every 30-minute, and then every 60-minute neuro assessments to continue after that. Remember, you're doing your vital signs, your blood pressure, everything else, assessments too. I found this drawing that I thought was just excellent in trying to bring everything together on your symptoms, that sudden onset, tachycardia, the embolus causing that infarct. Here's your chest x-ray if it shows up on there. A wedged opacity because there's no oxygen flowing through that area. Risk factors such as malignancy that I mentioned is pretty high. Going to treat managing their pain, giving them fluids, anticoagulation. Okay, nothing else on that. I just thought that was a good picture for you. Okay, so surgery for a pulmonary embolus. Surgery is after the fact, especially if they're high risk for forming more, or if there's multiple DVT, deep vein thrombosis, that's had the potential of moving. They will put in a vena cava filter. I don't know if you could tell from this picture. Of course, this is magnifying. It looks literally like a net or something you might use for fishing or something. It's metal. Well, it's not metal. It looks like metal, but it's just this whole mesh thing. So it is inserted and sits facing downward. They put it in through the groin, slide it up and implant it there so that it catches the clots as they come up. Umbrella-like filter through the inferior vena cava, trap large emboli, allow continued blood flow through and around the filter, just the large clots that get stuck. Inserted percutaneously. I've never seen it inserted jugular. I know it can be. I've only seen it put in femorally. So pulmonary embolus risk in children. Risk factors are listed here: obesity, immobilization, indwelling central line, malignancy, prior PE, DVT. Same thing with adults. Symptoms: tachypnea, tachycardia, chest pain, shortness of breath, and cough, just like the adult. Diagnostic tools for the adult may not be predictive of children, and they're treated with unfractionated or low molecular weight heparin. Unfractionated is your regular old heparin that you give IV, possibly sub-Q. Remember, your low molecular weight heparin, enoxaparin or Lovenox, is given sub-Q. Nursing process, your whole purpose is, again, prevention. Early ambulation after surgery, anything to prevent a deep vein thrombosis. Your leg exercise, you're stopping, avoiding crossing legs, and mobile as possible, as soon as possible. Your assessment, observing for chest pain, shortness of breath, onset, severity, precipitating factors, any history of recent surgery, venous thrombosis, childbirth, malignancy, anything that puts them at risk, any current medications they're on, and using one of the tools, criteria tools. Level of consciousness, vital signs, skin temperature, moisture, breath sounds, O2 sat, looking for neck vein distension, peripheral edema. If you remember peripheral edema, neck vein distension, or you are going to see with the right-sided heart failure. So if your pulmonary artery is obstructed, the blood's backing up into the right ventricle, right atrium, backing up into the body. Okay. So nursing diagnosis: impaired gas exchange, decreased cardiac output, ineffective protection, acute pain and anxiety. Your planning goals may include having O2 sat greater than 94, verbalize fears, obtain pain relief, show adequate tissue perfusion, have vital signs remain within normal limits. So you want to implement a plan to meet those goals. So to compensate for impaired gas exchange, you're assessing your respiratory status, putting them in high Fowler position or Fowler, whatever is tolerable to them. Again, you can look on your therapies on page 1301 or on your nursing care plan, which you have on starting on 1305, going to 1306. Bed rest, monitor arterial blood gases. You want to preserve your cardiac output, so you instruct on symptom reporting, skin color, temperature, auscultating the heart sounds. I would say at least every 2 hours. They stay on a cardiac monitor. Vasopressors if needed to keep the blood perfusion. They're having their watching for perfusion through the heart with your Swan or central line. You need to keep IV access. They may have an arterial line in, which is usually they would with this because you're doing frequent blood gases. Promote safety, assess medication regime for possible drug interactions, maintain adequate fluid intake, assess for overt, covert signs of bleeding. Overt signs, bleeding in the gums, petechiae, bruising, bleeding at insertion site. Covert signs could be your occult blood in the stools, in the urine, a lower H&H, maybe an abdominal distension, increasing in abdominal girth, something like that. Report coagulation study results if they're outside the desired range. Keep antidotes available, protamine for your heparin, vitamin K for your warfarin. Avoid invasive procedures. That's why you need your lines in before you start all the anticoagulation, especially thrombolytic therapy. Maintain firm pressure on puncture sites for an extended period of time. Relieve anxiety. Assess the patient's anxiety level, stay with them, explain procedures and treatments, reduce environmental stimuli, encourage family support, stay with the patient as much as possible. Morphine for pain management, and it helps with perfusion and dilation of vessels. Your evaluation expected outcome may be maintaining adequate tissue perfusion, patient's pain is controlled, maintains effective airway. Have assessment tools, treatment ready and available because they're at risk for, especially if they're at risk for another pulmonary embolus. Also look over on page 1305 of your text on patient teaching following a pulmonary embolism, how they need to take their anticoagulants, if there's lab works that need to be done, what they need to look for signs of bleeding, using a soft toothbrush, an electric razor to decrease the risk of bleeding on any anticoagulant, avoiding aspirin unless they're specific prescribed and told to continue the aspirin. Be careful with any over-the-counter medications because a lot of them have aspirin in them, or there's like your NSAIDs that impair your clotting. They need to wear a medical alert tag when they're on any type of anticoagulant. Health promotion to reduce the risk of recurrent PE, whether it mean obesity because of limited activity, because of tobacco use, which is a big risk factor. Teach them about the signs of a recurrent pulmonary embolus, such as sudden chest pain, shortness of breath, possibly bloody sputum. Your bloody sputums can come in when you have rupture in the arterioles in the lungs, and also assisting with smoking cessation. And that is the end of this lecture.